second. Order, order. I call Jane Hunt to move the motion.
I beg to move that this House has considered proposals to remove classification of prescription-only medicine from injectable B12 vitamin. It is a pleasure to serve under your chairmanship, Dr Hook. And I would first like to thank my constituent, Tracy Whitty, who since being diagnosed with B12 deficiency in 2012 has worked tirelessly to support others to get the treatment they have so desperately needed and campaigned for, to increase public awareness of vitamin B12 deficiency, as well as the issues surrounding access to treatment. It is clear that she is making a real difference to the lives of people across the country, and much of the information I will share today has come from her extensive investigation and research into this disorder. Vitamin B12 deficiency is a progressive neurological disorder with a wide range of symptoms which affect all body systems and, importantly, people of all ages. Indeed, statistics from the National Institute for Health and Care Excellence show that in the UK, 6% of people below 60 years of age are deficient in B12, rising to 20% in people aged over 60 years. This means hundreds of thousands of people are struggling with the symptoms of B12 deficiency, which can have a devastating impact on both physical and mental health, leaving sufferers unable to contribute to either family life or society. Crucially, due in part to the wide range of symptoms associated with the disorder, sufferers often struggle to receive the correct diagnosis, commonly being misdiagnosed with conditions such as Alzheimer's, bipolar, multiple sclerosis, chronic fatigue syndrome, autism, ADHD and fibromyalgia, meaning they do not receive proper treatment, which in the long term can lead to significant complications, including permanent neurological damage. Over the years, many people have contacted my constituent Tracy to discuss their experiences of living with B12 deficiency and the difficulties they have faced in getting the right diagnosis. I would like to share a couple of their stories. The first is that of a mother of 3 young children whose serum B12 level first indicated a deficiency nearly a decade ago. Sadly, however, this was overlooked, and despite being unable to physically function due to her disorder, the woman was repeatedly denied access to B12 injectables by GPs. After spending a number of years being passed from pillar to post, seeing a psychologist, endocrinologist, haematologist, gastroenterologist, pain clinic and chronic fatigue clinic, and being sent for a brain scan, the woman felt she had no choice but to resort to sourcing injectable B12 online. Thankfully, she is now fully functioning, but can she be certain of a trusted source for injections through the internet? The second is of a woman who, following 4 unsuccessful attempts at IVF, decided to explore B12 deficiency as a possible cause of her fertility problems, as she also had a myriad of severe neurological symptoms and a known family history of B12 deficiency. Over a year ago, she found out that she was indeed deficient when her serum B12 test resulted a result flagged as abnormal. However, along with the test result was a note stating that no action was to be taken, and so instead of treating her for a clear B12 deficiency, she was advised to take oral supplements and was referred to a chronic fatigue clinic. This woman is only just starting B12 injections with her GP this week, after repeatedly supplying evidence to them of the need for correct treatment. It is understood that oral vitamin B12 cannot be absorbed when the patient is B12 deficient. It requires an injection to be effective. Even when patients are correctly diagnosed, they often face an uphill battle to access the treatment they need when they need it. As the NHS website states, the treatment for those who are diagnosed with B12 deficiency depends on what is causing the condition, but most people can be treated with injections or tablets to replace the missing vitamins. It goes on to say that, at first, patients will have these injections every other day for 2 weeks or until their symptoms have started improving. After this initial period, if a patient's B12 deficiency is not caused by a lack of vitamin B12 in their diet, they will usually need to have an injection of hydroxycobalamin every 2 or 3 months for the rest of their life. Sadly, however, for many people, this maintenance dose is not enough, leaving them to deal with debilitating symptoms whilst trying to juggle the stresses of everyday life. Indeed, this has been the case with another woman who's been in contact with Tracy in recent months. During lockdown, this woman, who was previously being diagnosed with pernicious anemia, which is one cause of vitamin B12 deficiency, was exhausted, constantly nauseated, struggling with brain fog, and unable to function properly. She, therefore, asked her GP if she could have her B12 injections more regularly than the 8-weekly regime she was on. However, she in fact subsequently had her regime reduced to just 4 injections per year, after her GP took advice from a professor of haematology who, it would seem, incorrectly stated that a typical dose survives in the body for up to 2 years, and once the patient has the first few injections, there is no ongoing deficiency. We can be confident that these fluctuating symptoms are not related in any way to B12. This statement is at odds with NICE guidance, which is clear that the treatment of B12 deficiency in people with neurological involvement should include injections on alternate days until there is no further improvement. This left a single mother who was trying to cope with the additional stresses of homeschooling 2 autistic children due to COVID-19 restrictions, with no other choice than to purchase B12 online from a pharmacy abroad in order to function properly. It is because of cases like these that I presented a petition in the Chamber calling for the classification of prescription-only medicine to be removed from injectable B12 vitamin, so that those who have been diagnosed with B12 deficiency can access treatment over the counter at pharmacies when they need it. As the petition mentioned, this would bring the UK's approach in line with that of other countries, affording those with B12 deficiency the same dignity and control over their own health as a diabetic using insulin, and reducing the workload and financial burden on GP practices, district nurses and other NHS services. The latter point has become increasingly important given that COVID-19 has placed significant pressure on NHS services and, in recent months, intensified demand for GP services. It is also worth noting that since I presented the petition, Tracy's Change.org petition on this very subject has garnered over 96,300 signatures, reflecting the public interest in this matter. I am very grateful for the government's response to the petition I presented. However, it did raise a number of new issues, what I'd like to put to the Minister today. The government's response stated that clinically urgent treatment must always be provided with the patient's clinical needs being paramount. Any patient who wishes to discuss their need for vitamin B12 injections can request a review with their GP or other responsible clinician. However, in Tracy's experience, and as evidenced by the stories of those I shared earlier, clinically urgent treatment is frequently denied to those with B12 deficiency. This situation is worsened due to the COVID-19 restrictions, when many people with the disorder and pernicious anemia were told by their GP that they no longer needed B12 injections and could instead take a B12 tablet. Tracy heard how some of these GP practices came to this conclusion after taking blood to check B12 levels. This is despite NICE guidance and the British Medical Journal stating that no testing should be carried out once a patient is on vitamin B12 injections, as there is no indication of what is happening at a cellular level. The government's response also stated that vitamin B12 could not legally be classified as a medicine that can be made available for sale without prescription in pharmacies because it is an injection and because the condition it is licensed to treat, pernicious anemia, needs a clinical diagnosis to monitor it and its treatment. It is important to make a distinction here because, as I mentioned earlier, pernicious anemia is only one cause of vitamin B12 deficiency, and B12 injectables are also required by those who are B12 deficient for other reasons. Tracy feels that there is a widespread lack of understanding on this subject amongst clinicians, which is compounded by the inaccuracy of B12 testing. As the NHS acknowledges on its website, the currently widely used blood test only measures the total amount of vitamin B12 in a patient's body, rather than what the form is the B12 takes. This means that a blood test may show that a patient has normal B12 levels, even though their body cannot use much of it, leaving many patients without access to help or treatment. I would welcome the Minister's comments on whether the government will be working with the NHS to further clinicians' understanding of B12 deficiency, in particular the limitations of testing, to ensure those who are deficient receive better care. Finally, I would like to pick up on the wider point the government made in its response about the classification of B12 injectables. The response stated that before a medicine can be switched from a prescription-only medicine to a pharmacy medicine, ministers must be satisfied that it would be safe to allow it to be supplied without prescription. This means that it is a medicine which no longer meets any of the criteria for prescription-only medicine. The response went on to imply that, as B12 injectables are normally prescribed by a doctor for parenteral administration, they cannot be considered safe to be supplied without a prescription. This position seems to be at odds with the fact that private clinics are able to provide these very same injectables to clients, provided they advertise them using such terms as wellness, boost or supplement, and do not market them as treatments for B12 deficiency or make any medical claims. This is because the Medicines and Healthcare Products Regulatory Agency does not consider vitamin B12 injectables to be medicines in this instance. Indeed, in a statement to Tracy, the MHRA said, "Our current evidence to private clinics administering vitamin B12 injections, which are not licensed medicinal products intravenously for non-medicinal purposes, is what we do not regard these to be medicines and that they fall outside of the remit of the MHRA. It must be absolutely clear in the advertising of such products that they do not have a medical purpose." Furthermore, in order for staff at private clinics to be able to administer B12 injectables to clients, they do not need to have any medical training. The implication of this is that B12 injectables are simultaneously licensed medicinal products which are not safe to be administered by someone without medical training, and non-medicinal products which are safe to be administered by someone without medical training. Moreover, unlike with insulin, the risk of toxicity or overdose with injectable B12 is considered to be extremely low, and so would be relatively safe for those with a deficiency to self-administer. I would welcome the Minister's comments on these points. That being said, as the government's response to the petition rightly highlighted, self-administration would not be suitable for everyone, and so it would only be right that patients retain the ability to receive their injection at a GP practice. Tracy has also expressed that pharmacists who are already trained to administer vaccinations should be allowed to administer the injections to those with a prescription. This would allow pharmacists to play a greater role in community healthcare, relieving pressures on GP services. Here is another email I've received directly from a constituent. I suffer from B12 deficiency. At present, I require an injection every other day to keep serious neurological decline at bay. I was diagnosed last summer and rapidly declined to the point of almost being in a wheelchair. I was helped by the GP initially, but would not expect them to continue my intensive treatment owing to resources. However, if they could train us and supply the details, it would be better than as now, when many of us are forced to research this ourselves. I currently have to purchase ampules of hydrocobalamine online from Germany, which I'm sure you will agree is an expensive, lengthy and unnecessary process when they could easily be bought over the counter in the UK. The injections have enabled me to regain my peripheral vision, resume driving, function normally in a busy household, and even get a new part-time job. I cannot overstate the impact they have had on me, especially since the doctor suggested I might have terminal neurological decline. Please state the case for hundreds or possibly thousands of us in the same position, and for those who haven't yet been diagnosed and are struggling with poor mental and physical health for the sake of a low-cost vitamin. I hope that the overriding message the Minister takes away with her is the desperate situation that those whose stories I have shared today have found themselves in. So much so, they have had to source their own injections just to being able to function as she and I can. This debate today has been advertised on the B12 deficiency Facebook page. One lady has this morning left the following comment. Fingers are crossed. This would be life-changing for me and so many others. No more battling with my doctors. I can only dream of what it is like to feel alive. I would ask the government to please reconsider their position urgently. Thank you.
The question is that this House has considered proposals to remove classification of prescription-only medicine from injectable B12 vitamin. I call the Minister, Nadine Dorris.
Dr Hook, and it's a huge pleasure for the first time, I think, to serve under your chairmanship. And I think I was chair when you were an MP speaking, so it's the tables have turned. But it's a delight to be here. And thank my honourable friend for bringing this debate forward. Can I just say, though, that the points that she's raised in her speech, there were many. And actually, in order to do them justice, because we've only got 15 minutes, and in detail, I'm going to ask my officials who are listening in to provide a detailed answer to each of your questions. And I'm going to talk about something which I haven't been prepared to say, but I'm going to use this time because it's so important. And it's what she said in her speech that has made me think about something else. And that is, first of all, thank you, Tracy, your constituent, Tracy Whitting. And thanks to those of your constituents and other women who suffer from B12 deficiency. Every time you spoke about an individual case, you mentioned a woman. You didn't once mention a man. And I furiously fired off a few questions while you were speaking, and it is true that more women suffer from pernicious anemia and vitamin B12 deficiency than men. And this leads me into the Women's Health Strategy. And on the 18th of March, and Tracy, I hope you're listening, on the 18th of March, we launched a call for evidence for women to respond to tell us about the problems that they have accessing healthcare services. And I really hope Tracy is listening, and if she isn't, I hope you will get this back to her. Tracy will have a network of contacts of women who are suffering with this issue. For this issue to be addressed, we need to hear those women's stories. There is a very simple link on the gov.uk webpage. Those women can click on the link, and it would take 3 to 4 minutes to complete on their phones or their iPads a response to the Women's Health Strategy. It is so much less difficult rather than easier, so much less difficult to change policy if you have the evidence. And the default in health is male. And I'm afraid there are many conditions that affect women that it is very difficult to change. And I would cite an example, the response by Dame Sally Davis, which I think now is 3, possibly 4 years ago, and still there has been no major change. And NICE are going to be coming forward with recommendations. That may not be for another 12 or 18 months. It isn't fast enough. And my point on this is that's because it's because it's women, and women's voices are just not listened to. And I'm trying to change that. I'm trying to put women at the heart of health strategy and health policy. And if Tracy could just, I'm sorry to use a few minutes responding to get this point over, because I think Tracy could have, as well as with you today raising this issue here, which is vitally important, Tracy could also have massive impact if she could get those women that she knows, and using the forums and the platforms that she uses and is aware of, to post the link and make sure those women are aware so they can respond. So I just don't get, and it's vitally important that my honourable friend is here raising this on behalf of Tracy. But if we could have, hundreds of women, possibly thousands of women, who could respond to the Women's Strategy call for evidence, then that would be incredibly powerful, because that would give us evidence, and that would be data. And it wouldn't be one constituent of yours putting a story forward, it would be lots of them.
You will remember when you used to do this, that thing about saying you've done it a few times. Just I know Eleanor Lang, who's our boss nowadays, is quite hard on her. She said, don't let anyone get away. I've let you do it a few times, but if you can call her your honourable friend.
My friends, I did this all the time when I was in the chair, told people off for exactly the same reason. And I think it's because I am absolutely sure that it's due to the fact that we had a big gap with no debates over COVID. And I've just slipped back into a pre-being an MP habit of 20 years ago, 15 years ago, 16 years ago, whenever it was. So my absolute apologies. Well, I am, I can assure you. So to finish the point, if my honourable friend could ensure that her constituent responds to the call of evidence, that would be absolutely more powerfully useful than I think I've got to say in my response in this speech today. And we will respond to all of your points in detail. It was a you, not you. My honourable friend's points. I have said I want to. I'm going to go on to note some of the points. You asked specifically about making B12 injection available to purchase from pharmacies. So, as my friend raised, the MHRA is the body responsible for medicines licensing in the United Kingdom, and they're committed to making more medicines available over the counter. So I think we would already be pushing at an open door. And they are committed to do that where it's safe to do so as an important element of the self-care agenda in empowering patients. So my honourable friend mentioned pharmacists and the role of pharmacists, and we've seen the step up in the role of pharmacists during COVID and the vaccination programme. And that was an incredibly important point, because I know my honourable friend who actually has pharmacy in her portfolio is constantly looking at ways to increase and enhance the role of pharmacists. And this seems to me like it could actually be a very useful way where we could tie in enhancement to the role of pharmacist with an issue such as this. And I used to be a nurse who used to give vitamin B12 injections years ago. And I was trying to rack my brains. I don't remember ever having given one, but I'm sure I probably did, as men do suffer from this as well. But it's a really interesting phenomena, and I think it's also interesting that we could, with a bit of imagination and working with clinicians and harnessing the expertise and the knowledge of pharmacists, find a new way of doing this. The MHRA is a well-established process and procedure for moving medicines from prescription-only status to over-the-counter, which I'll refer to as OTC, when it's safe to do so. And to reiterate, this is a medicine which is not like, and OTCs are medicines which are not likely to present a direct or indirect danger to human health, even when used correctly, if used without the supervision of a doctor, or if not frequently and to a very wide extent used incorrectly, and as a result is likely to present direct or indirect danger to human health, and does not contain substances or preparations. And there's an entire list which we will include in the letter to you. To date, the legal classification of all currently authorised medicines for injection, including vitamin B12 injections, is prescription only. But other factors support this position, in addition to the fact that the product is injectable. The main reasons as to why it would not be a suitable candidate for reclassification under the existing place where we are now in guidelines is that the product is considered to meet the prescription-only medicines, the POMs, as set out in legislation. And in particular, pernicious anemia or any other cause of vitamin B12 deficiency cannot be self-diagnosed and requires the expertise of a medical doctor. And I think the NICE guidance also says that when someone presents with the signs and symptoms of pernicious anemia, they do, contrary to the comment that she made during her speech, the NICE guidance is that the patient does have a full blood count as part of the diagnostic process. We're also aware that there's a high risk of off-label use by patients. And my honourable friend mentioned the fact that private clinics are injecting for wellness. It is currently only authorised to be used in maintenance therapy for pernicious anemia every 2 to 3 months, depending on the type of pernicious anemia. And anecdotally, we hear that patients would consider a more frequent administration of the medicine to be appropriate for their particular clinical symptoms. Any reclassification of the medicine would not change either the dose or the frequency of the treatment that is set out into the terms of the product's marketing authorisation. I'm also led to believe that the evidence of lifestyle abuse of unlicensed formulations of B12, which, whilst not necessarily relevant to the particular patient group like Tracy and the people my honourable friend has spoken about, is also taken into account in determining the legal classification of the medicine. So that is an issue which does have to be considered. There are people who do abuse and would abuse this, but that doesn't mean that because there is a particular group that would overuse and abuse the availability, that we should just say we're not going to continue to look at this. And although that's not in my speech and hasn't been advised to me, I'm making that point. We shouldn't use that just as that we don't go there. And you know, I'll go back to the point, and I won't apologise for banging on about it. It affects more women than men, and therefore, as part of the women's health strategy, we should be pushing those barriers back and looking at different ways to deal with this. Taken together, these issues mean that the criteria for prescription-only medicine have been reached, and changing the classification would therefore not be appropriate. And you know, that part of the information that I've been given, you know, I think needs to be challenged. that it's not appropriate, we need to challenge that. We need to ask why not. But, you know, vitally important that we get the evidence back from the networks and the forums that Tracy knows. I note that this issue has been before health ministers in recent times, and as I mentioned, Dame Sally Davis, our previous Chief Medical Officer, did engage with the Medical Royal Colleges to raise the awareness of the condition, but it's taken too long. You know, that was, I think Dame Sally retired 3 years ago now. It's taken too long. And following on from that interaction, NICE have worked to develop and publish an updated clinical knowledge summary on pernicious anemia. And this sets out clinical guidance on diagnosis, treatment and management of the condition, which should be followed by general practice physicians and others responsible for the care of patients who suffer from this condition. The updated guidance was published in July 2020 and should now be a regular part of clinical interventions in general practice and secondary care. I'd really be interested to know what Tracy's experience of that is, and whether or not she thinks that she believes that the guidance has been implemented, and particularly from the forums of other women that she's speaking to, has it been implemented? Are GPs aware of it? It will be, if you know, in the responses to the Women's Health Strategy, if they could let us know, that would be incredibly important. And I say it is important to evaluate the impact that has had on the clinical management of pernicious anemia moving forward before considering further regulatory options. NICE produces guidelines as quickly as possible. I don't think in this, an amazing organisation that does very good work, but in this and other women-related issues, I think we do need to move a little bit faster. Regarding your question on the private injections of B12, as I said, there are two separate types. Licensed products must be administered by prescription by a suitably qualified healthcare professional. That's where we are at the moment. Private clinics are not providing the same injectables to clients as GPs are. I think that's an important point to make. They are providing injectable vitamin B12 products which are not licensed medicines for general health and wellness purposes. Of course, if clinics make medicinal claims for unlicensed vitamin B12 products that they offer, then the MHRA would take action. And also, when classifying products, MHRA are bound by case law to consider products on a case-by-case basis and cannot automatically classify all vitamin B products as medicines, so they don't all meet the criteria to be classified as licensed medicines. I think that's an important point. Closing, I would like to thank my honourable friend for continuing to raise this important issue on behalf of her constituents and everyone affected by the condition. We'll continue to work with and support the NHS and NICE who are actively engaged in this issue, and clinicians to understand the importance of B12 deficiency and guarantee that patients are receiving the best possible care. I think the Women's Health Strategy will really help in that. I think it will possibly be the boost to move this forward by the evidence that we can gather. I would like to finish on that point, because I think the evidence that Tracy and those who use those platforms and yourself and others who complete the Women's Health Strategy could really give us important evidence that we need to hear and we need to know to enable us to push forward to now, I'm not saying that means we don't know what policies we're going to develop from the Women's Health Strategy, but if there are enough women responding saying that this is an issue, then that certainly gives them a voice, and it certainly gives us a lever to pull in order to try and. But I think the biggest one of the biggest issues here is the time that it's taken to bring about change. The guidelines went in. Be interested to know how they've bedded in. Be interested to know whether people like Tracy's forums think they're being used, and if they've made any benefit. And I'd also be really interested to hear, we would be interested to hear what the problems are in terms of prescribing and the issues that they have in administration. Thank you, Madam Chair.
The question is that this House has considered proposals to remove classification of prescription-only medicine from injectable B12 vitamin. As many as are of that opinion say aye.
Aye.
Of the contrary, no. I think the ayes have it. I think the ayes have it. Order, order. So sitting suspended till 4.